The first slide that we're going to examine today is located in your slide library. If you look along the left-hand side of your screen, you'll see a category named Interface and Lichenoid Reaction Patterns. Click the drop-down button on the left-hand side, and the first diagnostic category you'll come to is Dermatomyositis. The slide which we will review is the first slide in this category. Whenever examining a microscopic slide for the first time, you want to take a low-power view of the slide so that you can begin to pick up some characteristics of the specimen that will help you form your differential diagnosis. In this particular case, we can see at low-power view that the epidermis is relatively unremarkable at this power, and that we have an inflammatory infiltrate within the dermis that seems to be located mostly around the superficial vascular plexus and even the mid to deeper reticular vascular plexus. We then systematically review the slide by going through the entire specimen from the epidermis to the reticular dermis and subcutaneous tissue. We'll start by looking at higher power along the epidermis. So the first thing we always want to take note of is a stratum corneum. In this particular case, we can see a mostly basket-weaved stratum corneum. Within the epidermis, you can begin to make out at this power a few pink dyskeratotic cells, as well as focal areas of vacuolar change along the dermal-epidermal junction. We'll take a look at this at higher power. Now, at higher power, we can begin to appreciate better the basket-weave stratum corneum, the areas of vacuolar change along the dermal-epidermal junction, and occasional dyskeratotic keratinocytes, which appear pink and are mostly scattered as single cells along the basal layer. This places us into a diagnostic category of interface dermatitis. The next thing we want to do is investigate the inflammatory infiltrate further. And to do that, we're going to go to lower power. So at lower power, we can begin to see that we have an inflammatory infiltrate around the superficial vascular plexus that also extends into the deeper reticular dermis. Next, we want to take a look at some other characteristics of the dermis that may help us to better differentiate this particular lesion. So as we go to higher power, we can start to appreciate that there is some fenestration of the collagen with this bluish material that is present between the collagen bundles. Now, if we were in the papillary dermis, this bluish material may simply be solar elastosis. But in the deeper dermis, I think you can better appreciate that we're seeing increased amounts of dermal mucin present within the specimen. So let's back up and take a look at our specimen again in low power. What we're seeing are three characteristic findings, and those are vacuolar changes along the dermal-epidermal junction and a superficial and deep inflammatory infiltrate that is mostly lymphocytic with increased dermal mucin. This leads us to two diagnoses, one of which is dermatomyositis. The other diagnosis to consider for this specimen is lupus erythematosus. With lupus erythematosus, you typically see more pronounced vacuolar changes along the dermal-epidermal junction. In addition, there may also be a more pronounced flattening of the epidermis so that the ridge pattern is not as intact as one might see in this particular instance. Now, many dermatopathologists find it difficult, if not impossible, to differentiate between lupus and dermatomyositis on a microscopic slide. And oftentimes, when rendering a diagnosis, one will place in the comment that it is difficult to differentiate between these two entities histologically. And this is certainly the case most of the time. Obviously, one would need additional studies as well as clinical findings to help differentiate the clinical diagnosis of dermatomyositis from lupus erythematosus. What are some other characteristics or other conditions that we might consider in the differential diagnosis for this case? Well, as we are dealing with an interface dermatitis, one possible differential diagnosis would be erythema multiforme. However, in erythema multiforme, we would typically expect to see many more dyskeratotic or apoptotic cells present along the basal layer, with some cells extending into the upper epidermis. In addition, you wouldn't typically find the increased dermal mucin that is noted in this particular specimen in cases of erythema multiforme. The one characteristic that this specimen has, which you can also see in erythema multiforme, is a relatively intact basket weave appearance to the stratum corneum. However, the other features which we have mentioned help to differentiate this particular case of dermatomyositis from erythema multiforme. How about graft versus host disease? Well, typically graft versus host disease doesn't show as much thinning of the epidermis as one would see in cases of either dermatomyositis or lupus erythematosus. In addition, you'll typically see more hyperkeratosis and parakeratosis, and at times accentuation of the granular layer. The necrotic keratinocytes that are present in graft versus host disease may be present as single cells along the basal layer, as you will see in dermatomyositis, but in graft versus host disease, these cells may also extend down adnexal structures.